Hi, good afternoon, and thank you for coming to this session. And for those online, thanks for attending. I'll be moderating this. So if you have to ask a question or like to ask it, no, I shouldn't put it have to. When you want to ask a question, just stand up. I'll bring the microphone over so that the people online can hear you. A reminder, this session is recorded and will eventually be posted on our YouTube channel and our website. So keep that in mind. Anybody online, feel free to chat, put any questions you have on chat, and I'll ask Lisa. Would you like me to leave the questions to the end, Lisa, or let you have it when you have a break here and there? What's your preference?
I don't have a preference.
Perfect. Fair enough. Then, given that, Lisa, we'll go as they come, sort of thing. We'll sort of jump in naturally. Thank you for lending your expertise, for being here. I see you brought your contingent with you, which is great. Uh, and you'll do a much better introduction of yourself than I will, so I'll let you take it from here. Thanks, Lisa.
Thank you, Ron. Thank you all for spending your 4 o'clock hour learning about newborn screening. It's something I find very fascinating, but it's also something that's more complex than I ever could have dreamed. So my hope for today is that you will leave with a little bit better of understanding of it, but also hope. I hope that you will feel hope that it's a worthwhile cause for any condition. I know what states most of you represent. What state are you from? Ohio. Okay, that just gives me a better idea. Okay, so I was honored to be asked to come again this year to do basically like a newborn screening 101. But then, so the first half will be, maybe I have an overview slide. I guess I should look. Oh, here are my disclosures. Okay, so the first half will be newborn screening 101. Here's what it is. And then I'm going to talk a little bit more about how you specifically can be active in your state. But for those who don't know me, my name is Lisa Brackbill. I live in Hershey, Pennsylvania. Yes, where we make chocolate, but I'm from California. I've been married to my husband, Brennan, since 2010, and we have 3 children, Victoria, Isaiah, and Caleb. Isaiah and Caleb are identical twins you might have seen running around. I have a bachelor's degree in political science, and I just completed my master's degree last month in strategic communication. I'm not sure that was the wisest move while having twins, but you know, I did it. I'm an author. I've been an advocate for newborn screening since 2015, and I helped start the Leukodystrophy Newborn Screening Action Network, or LDNBS, in 2020. But before I begin, and I am going to use notes during this because I have twins and that's just my excuse. My memory is not what it used to be, but I always honor my daughter first and foremost. My daughter Victoria had Krabbe disease and she passed away in 2016 at 20 months of age because she was not screened for Krabbe disease at birth. So she is the reason that I have become an expert in newborn screening and in newborn screening advocacy in the United States. It was because of her that I fought over the course of 5 years with 3 different bills to reform newborn screening in Pennsylvania, which ended up making our program one of the strongest in the country. It is because of Tori that I persisted in advocating to the Newborn Screening Advisory Board in Pennsylvania and convinced them to add Krabbe disease, which was one of the greatest accomplishments of my life because they were really set against it when I first started, making Pennsylvania the 9th state to start screening for Krabbe. And it is because of Tori that we identified 4 babies with Krabbe disease in our first 7 months of screening, including identical twins born on her birthday just 2 months after we started. So she gets all the credit for everything that has come since she was born. So I always like to honor her. Okay, so we're going to talk about these things today. As I mentioned, we're going to talk about what is newborn screening, the status of newborn screening for leukodystrophies, and then what you can do in your state, as well as resources that I've helped to create to educate and equip advocates, because not everybody needs to know everything that I know about newborn screening. So this is our mission statement for LDNBS. We focus on advancing newborn screening, supporting newly diagnosed families, and encouraging collaboration between industry advocacy groups and parents. Because one thing that we saw, this organization was co-founded by Maria Kafalis, who got the award last night. She reached out to me in 2020 and she said, I see the work you're doing. I have an idea and I want you to do it. I didn't know that meant that I was going to literally be starting this from scratch, but she had faith in me. But she saw that so many conditions were starting from scratch and reinventing the wheel when it came to newborn screening. And she's like, why? She's like, I don't want to do this with MLD. And she wanted this work to become a legacy for other leukodystrophies. So that's why we started. So What is newborn screening, or as you often see it abbreviated, NBS? I like to start with a quote from the man who started it all, Dr. Robert Guthrie, who said, "No child should die or suffer disabilities if a simple blood spot can prevent it." He developed the newborn screening test for PKU in the 60s. Some people still refer to it as the PKU test. Please correct them because it's obviously so much more than that. But it was because of families that he got to do this at all. So, the most important thing that you can learn about newborn screening is that it is not just a test, it is an entire system. It involves scientists like Dr. Gelb who create these assays so that we can even detect these conditions out of blood. The lab technicians in the state labs and the private labs who run the tests, who run the newborn screening assays to see if they can find anything. The state newborn screening programs who deal with the follow-up, they're the ones who contact either the pediatricians or the parents, and they keep everything running. And then the clinicians and the specialists who will eventually see these patients, and they have to know what to do with them, which, as we know, for leukodystrophies is not always clear cut. Newborn screening actually also is not just the blood spot test. It's three things. It's the dried blood spot, which is what we are all interested in here. But there's also a pulse oximeter screening, which is looking for heart defects, and the hearing screen, which looks for severe to complete hearing loss. So what is the lab looking for? I'm going to use Krabbe disease and MLD as an example because those are the ones with which I'm most familiar. So with Krabbe, they are looking for low GAL-C enzyme levels. And if that is found, then they look for high cycosine, which is the toxin that builds up because there's no GAL-C. And then they would also, at the same time, in most states, reflex to sequencing. So they immediately do genetic sequencing to look for known mutations. With MLD, it's similar. They're looking for elevated sulfatide levels, and then they're looking for ARSA, which is the enzyme that's usually missing, and then they look for gene mutations. And of course, because this is the United States, every state does this very differently. And from an advocacy perspective, it's really not ideal. But this is just a few examples, and we're going to go into some of this. But some states use their own lab that they then have to fund. Some outsource it, whether it's to a private lab like Revity or to another state. Each state has a different number of conditions on their panel, which actually, I was just in DC before this conference because I'm on the ad hoc committee of the advisory board, the federal advisory board, to fix this problem. So we are working on fixing the counting conditions thing because every state also counts their conditions differently. It's really great. They add conditions differently, though most states have a process, and we'll talk about that. And then how they fund it. It's different in almost every state. And I have done my best to figure it all out so you don't have to. So advisory boards are actually one of my favorite things for the most part. Of course, in some states, they don't work as effectively as others, but typically, a committee is composed of geneticists, pediatricians, specialists, and parent advocates. They review conditions that come forward, but they also look at the program as a whole, and they try to fix it. I have been on the LSD subcommittee of the Pennsylvania Newborn Screening Advisory Board for about 6 years. So I've been able to see the inner workings, at least, of how Pennsylvania works. But of course, the authority differs from state to state. So in Pennsylvania, part of my work was to give complete authority to the actual experts in these conditions to decide what should be screened for instead of having politicians decide, because they aren't the experts in a lot of things. So some states some states have the direct power, like Pennsylvania, and Iowa, and there's a few others, to add conditions. What they say goes. Others recommend to their state secretary of health, or there are a couple that do require legislative approval, but that's usually because the state funds it that way. So they have to go ask for money. And newborn screening is often not a priority. So that's why we took the legislature out of the equation in Pennsylvania. So I'm sure you've heard this acronym too, the RUSP. If you haven't, you will become very familiar with it as you pursue newborn screening. It's the Federal Recommended Uniform Screening Panel. We are actually still waiting for Krabbe disease to officially be added, even though they voted to recommend it in January. The Secretary of Health has 30 more days, I think, to decide. But it was implemented in 2010 to encourage uniformity between states. And we think it's bad now with some states, again, saying that they count or they screen for 35 versus California that screens for 80. I mean, like, it's a bad discrepancy. Back then, there were some states only screening for 4 conditions. So we talk about death by zip code in the rare disease community. It was really bad. So the American College of Genetics and Genomics convened a meeting to try to make this a better problem. So they looked at a whole bunch of conditions and they decided on an initial list that I can't remember exactly how many were on it, but currently there are 37 conditions on the RUSP. 37. Remember, there's like 10,000 rare diseases. These are recommendations to the states, not requirements. And this is all overseen by the Advisory Committee on Heritable Disorders in Newborns and Children, or as we say, the ACHDNC, because that is a mouthful. So this committee was formed as a result of that work. They meet 4 times a year, and then they ultimately recommend or don't recommend conditions to the RUSP. So as I mentioned, Krabbe disease is about to be added unless something really drastic changes and the secretary decides no. MLD just submitted on Thursday. So the MLD submission is in, and I know CTX is coming as well. So we're about to see some leukodystrophy action. Yes. Not most. I will talk about that too. So good question. More and more, there are states adopting what they call RUSP alignment policies, but it's still only, I think, about 15 that actually have it in place. That is, yes, because I love scientists. We couldn't be where we were without scientists, but I've never seen so much infighting about things. I mean, it's crazy, but I love that because that's how we get the truth, right? Like they compare their data and they figure out like, okay, this is reality. But sometimes I'm like, can you just trust somebody? But actually, yeah, the very next thing I was going to mention is RUSP alignment. But I forgot because I hadn't looked at my next slide. So no, it's fine. So this slide is already out of date because we had to turn them in earlier this month, and now there are 43 states screening for ALD. But I use this as the example because ALD was added to the RUSP, I believe, in 2017. Let's look at my notes. 2016. And still not all the states are screening for it. This is a big problem, and that's why groups like the Every Life Foundation for Rare Diseases began RUSP alignment policy campaigns. So what these are bills that get signed into law stating that these states have to screen for whatever is added to the RUSP. It's a good idea in practice, in theory. In practice, of course, these bills have been changed as they've gone through the legislatures. Ideally, they would add them within 2 years of addition to the RUSP, but some states have stretched it to 3. Some have taken the timeline out at all. So again, everybody does it differently, but right now, those are the states that have one. And Wisconsin had one in the legislature, but it didn't get through in time. So I think it's going to be reintroduced. So we're going to now jump to what are the ethics of newborn screening? This criteria was developed a while ago. I don't actually remember when Wilson and Youngner did this, but they looked at what should be screened for and what should be the criteria. So I'm not going to read these, but basically there has to be a well-defined test that works. The disease needs to be understood. And I don't know about CTX or your conditions, because I don't know exactly what conditions you have, but I know for Krabbe, there are over 200 genetic mutations that can create, I don't even know the math of the number of different, types of severity of disease. So it's very challenging for these physicians to know exactly what the disease is going to look like in the child. But we still have enough of an understanding that we got it through. There has to be a treatment. That's the biggest thing. There has to be a treatment because you can't, as a public health program, they can't maybe do this mandatory thing that parents don't even know is happening. And then be like, oh, I'm sorry, your kid has this. Your perfectly healthy looking newborn has this terminal disease and we can't do anything about it. So that's basically what it is. And then, of course, the overall benefits of screening should outweigh the harm. And I've sat in way too many conversations about benefit versus harm. I mentioned this earlier, like why some states say they count for 8, they screen for 80, but some only say 35. And yes, we are fixing this problem. But basically, there are what they call core conditions on the RUSP. There are 37 currently. Those are things that the states are explicitly looking for in the lab. Secondary conditions are ones that they might happen to find, but they can't guarantee that they would find every single case. So using MLD as an example, multiple sulfatase deficiency can be detected as a result of screening for MLD, but they can't guarantee they will catch every single case of MSD. So I don't know that MSD will be listed on the secondary list or not, but that's, oops, I need to do that. So some states add those numbers together because they're like, well, this looks really good. Missouri's another example of one that counts all of this. They say they count for that they screen for 77 conditions. Some of them do have additional conditions that are not on the RUSP, and they add those. And then even worse, some will take, like, for instance, they'll say we're screening for infantile Krabbe and late onset Krabbe, and that's 2 different conditions. It's a problem because advocates who don't know, or parents that look at this and they don't know this complexity, they're like, well, my state is terrible, and they get mad. I used to be one of those parents that was very mad. And now I'm like, well, this is just dumb, and that's why we're fixing it. Okay. So right now, this is the status of ALD newborn screening, though, like I said, I think I actually am one state behind. So ALD is in good shape, but it has taken far too long. And all these maps are available on our website too. This is the status of Krabbe newborn screening. But since I made these slides, Iowa's Newborn Screening Advisory Board agreed to begin screening. And so they are going to begin the pilot study in about 6 to 9 months. So we're very excited for reasons I'll mention in a few slides, but Iowa is a very important state. MLD, both Illinois and Tennessee are working on implementing newborn screening, and Pennsylvania will be right behind them. MLD is also on the Screen Plus pilot in New York. And then CTX is on the Screen Plus pilot, and it's nowhere else yet, right? I didn't think so. Okay. It would depend on the condition.
One sec. They're saying they can't hear the
Yes,
questions.
there was a specific state that's easier to get a condition on than others. It definitely depends. Missouri has been an early adopter in a lot of cases. Pennsylvania now is very open to it, but again, the science has to be there. So there are definitely states that are easier, and a lot of it has to do with funding. Like Louisiana is always going to be one of the hardest because of how they fund their public health system. So yeah, Missouri, any of these on the Krabbe list, some of these were legislatively mandated, but some of them were done through the advisory boards, and they were very open to it. So all that to say, it just depends, and I'm sorry that that's not a better answer. I wish it was just everybody does what they should do. So this is a brief look at Screen Plus. It is a consented pilot study that is happening, I believe, in 11 hospitals in New York City. And we were lucky that 3 different lysosomal storage disorders, leukodystrophies, and all of these other lysosomal storage disorders were included in this pilot. So far, the only leukodystrophy that they've picked up in this pilot is CTX. So we're happy because in order to even apply to the RUSP, you have to have what's called N of 1, which means that a pilot study has prospectively found a newborn through newborn screening. And so now CTX has that. So another question I get asked all the time, why aren't states screening for everything that they could screen for? That is definitely one of them. So I'm going to list some of the main issues. So one of them is that 12 states use another state's lab instead of having their own. This is smart in a lot of ways. And I know this is small, but the reason I mentioned Iowa earlier is because they do the newborn screening for the Dakotas and Alaska. I don't know how these partnerships were formed. I mean, Alaska to Iowa is not, I don't know, but it's great. So once Iowa has the capability to do this, the other 3 can. They still have to choose to add it. Massachusetts does the newborn screening for all of New England except for Connecticut. So you can see that some of these states, like we'll use New Mexico as an example, they've had a law in place to screen for Krabbe disease for more than a decade. They can't do anything about it until Oregon starts screening. So if your state is not screening for your condition, there could be a practical reason like this. That didn't translate well to a slide. Sorry. These states outsourced to Revity, which used to be known as Perkin Elmer. It is a private lab. Yeah, so Pennsylvania does this. This is why we can add conditions in 6 months, because Revity is the one developing these newborn screening assays. They are the ones who have the technology. We just say, please do this, and they do it. So we have that advantage, and these states do too. So these states, honestly, they have fewer excuses. I'm looking at you, Bob, for Nebraska. I'm just kidding. I know. I know. I know better than anybody how complicated this is. But these states, in theory, can just say, we want to start doing this. How much does it cost? Let's do it. So we mentioned Rust alignment states earlier. Not all laws are written well. This is why I really don't believe in legislative mandate for adding newborn screening conditions. But even some of these Rust alignment laws, as they've gone through the legislatures and they've been changed, and I'm going to use California as the example. California's Rust alignment law was actually one of the first, if not the first, and it was passed in 2012. They can only add Rust conditions. So even in a state with such a high birth rate that would be so amazing to be able to start screening for early things, they are not allowed to. That's why in Pennsylvania, I made sure that we added verbiage that the advisory board can screen for whatever they want, because I watched this happen in California. And I think there's another, Arkansas. Since I last spoke here last year, Arkansas passed a Rust alignment law. They did the same thing as California. And I don't know that they meant to, but I really wish politicians would leave things alone. But as you said, a lot of it does come from a lack of funding, but I want to emphasize it's usually not from a lack of desire. I have worked with so many newborn screening programs now. They are some of the most dedicated, passionate people you ever meet, and they choose to stay in public health. They could make a whole lot more money if they went to private labs. They choose to stay in newborn screening because they're passionate about it. These advisory boards are volunteer in most states, if not all. They don't get paid to do what they do. They do it because they care. So rarely is it because they hate your condition and they don't want to screen for it. I'm not saying this never happened, because I encountered that. But a lot of times it has to do with how the state funds newborn screening. So as I mentioned, in Pennsylvania, we took the legislature out of the equation altogether, which not every state can do. But we restructured it so that insurance is paying for newborn screening, which they are federally mandated to do. So if you want to fix something in your state, you could do that. The other problem at the federal level is that the Newborn Screening Saves Lives Reauthorization Act has not been renewed since, I think, 2018 because of one senator. One. He's from the state of Kentucky. That's all I'm going to say. It's really hard because, because of how divided and how partisan Congress has become, one person actually makes a big difference. He thinks that newborn screening should have to be a consented program, and for so many reasons, it's not. And so that's what's holding it up, is consent. We all in the newborn screening committee, community, we believe that once we get to like genetic sequencing for newborns, like 100% that should be consented, because you may learn things you didn't want to know about your child. But newborn screening, no, because we know we'd miss babies. So anyway, because of this, there's federal funding that is not being sent to states for years now. So that's part of the reason. So money is always a problem. There are a couple of potential hurdles that we've also faced in the newborn screening community, two of them being dried blood spot lawsuits. So every state, shockingly, right, holds their dried blood spots for a different length of time. Some of them, this actually is detrimental to research too. Some of them destroy them after 30 days. Why does this matter for rare disease? We often don't know that our child has a rare disease at 30 days old. Some of that information can only be found from obtaining that dried blood spot, and a lot of that falls on advocacy. For instance, the AGS community, they reached out to me a couple years ago, and they were like, we have to obtain dried blood spots for our kids so we can validate the assay. And I'm like, I don't know how to do that. And a lot of them had already been destroyed. So in Michigan, this one, I think we're actually still waiting on the circuit court to give a ruling. 4 sets of parents who had consented. Michigan actually has one of the most thorough consent for storing the dried blood spots that there is. These parents consented to have these de-identified, which means they're anonymous, blood spots stored in Michigan to be used for research purposes. They later sued the state, saying that it was unconstitutional, and it made it up to the circuit court. This can have huge ramifications for newborn screening on so many levels. Thankfully, the media kind of has calmed down about it. It made it in like maybe 4 news pieces that I saw. The New Jersey one, on the other hand, they actually just also solved last week. In New Jersey, law enforcement used dried blood spots because they store theirs for 23 years, some really random number to me, um, to convict the baby's father of a crime. That's not okay. And so New Jersey actually did, just like in the last week, put some restrictions up around that. But whenever newborn screening gets in the news for something like that, it immediately creates distrust. And then we look at the amount of distrust of public health by some in our country after COVID. Newborn screening is public health. So in their minds, they hear public health, they think bad, they hear newborn screening, there's just a lot of potential hurdles. But now we're going to shift to what can we do with all of this complexity, because there are some very practical things. The first thing that we can do is to learn as much as we can. And that includes knowing your disease, and I'll define that in a second, knowing your state, and knowing your story. We can listen to understand, but most importantly, we can collaborate and communicate. And what do I mean by that? Okay, so the 3 pillars of the LDMBS newborn screening advocacy policy, wow, it's late in the day. Mindset, the word totally escaped me, are these 3 things. And we labeled them in this order because it's most important to know your disease and to know if it's even capable of doing newborn screening. With more than 50 leukodystrophies, there are actually several that will never be good candidates, or they don't need to be because they're adult onset conditions. Right now, there are only 4 leukodystrophies I'm aware of that are even able to be advocated for right now, which are ALD, Krabbe, MLD, CTX. AGS is getting close, but they're not there yet. So it's just really important to know if this is even worth your time and effort. But we do encourage you to help other conditions, 100%. If you want to advocate, there's plenty of work to do. Knowing your state, as I went through earlier, it's complex. Every state's different. So you really need to understand who the players are in your state, what you can actually do, who to talk to, and I'll go through that too. Oops. Apparently I deleted a slide. Okay, pretend this is highlighted. Knowing your story we put as last because it's actually the easiest part. Oh wait, nope, I didn't. Never mind. Back to knowing your state, I forgot. Yes. As an example, my home state of California, it's important to know these things. They don't have an advisory board because they rely on the RUSP. They do add conditions within 2 years of the RUSP, but as I mentioned before, there is no advocacy pathway because of how their 2012 law is written. So I guess we could go in and change that, and that would make their newborn screening program very happy. But that's why we can't even legislatively mandate in California. Rhode Island is an example of, they do have an active advisory board that has power. They add conditions within 2 years of the RUSP, but because they use Massachusetts newborn screening lab, they cannot add conditions until Massachusetts can actually screen for them. So those are some challenges. Okay, knowing your story. It's the easiest part, right? We all have lived this journey. We know the disease. We know why newborn screening is imperative. But there's still refining that can be done. So as you're crafting your pitch, these are things that I would consider. One is to know, or look at the known and the potential obstacles that you would face in your state or about your condition. So we hear about Krabbe disease all the time, like, well, we don't know whether or not they should be treated or not. There are things data you can use to counter that. You can also now for Krabbe say, look at these, there's 12 states screening for it, 13. It's late in the day. You can look at these other states that have been successfully doing it. It's possible. You also have to know what will speak the listener's language. So in my case, I had to speak differently to the Newborn Screening Advisory Board than I did to the legislatures. I was trying to get them to fix things. You can compare to other states, use data and statistics. You can also mention that it does save the state money because most of these kids end up being on Medicaid, which comes some from state funding. They like saving money. And then I want to encourage you that while you can offer a solution to the problem when it's possible, it's not your job to actually figure out how to solve the problem. Your job is to tell these decision makers, this is a problem, fix it. So don't put that burden on yourself of figuring out exactly what you need to do. And I like these two quotes because I think it emphasizes what I just said. So the first one is, without data, you're just another person with an opinion. And that especially matters in the scientific community. But then I like this one that says, maybe stories are just data with a soul. Because showing our children's faces puts a face to that. And actually, while Tori was alive, she did get to come a couple of times to the Capitol with me. And them seeing her, seeing us use the suction machine, all of those different things did make an impact. This is my favorite thing. Of all the things that I have learned since Tori was born, I've learned that if we want decision makers to support us, we must be willing to listen to them. And I'm not saying this is easy, but this has truly changed my life. And that, I know that sounds dramatic, but it absolutely has. So listening and understand requires humility, a willingness to be wrong, and the ability to change one's mind when new information is obtained. It humanizes those on the other side and helps us better understand the motivations behind their stance. This obviously applies to everything in life, but I'm going to show you what it looks like to listen and understand. And you can enjoy this picture of our ceremonial signing. When I first started trying to reform things in Pennsylvania, I had no idea what I was doing. I didn't understand how complex this newborn screening system was. I was a grieving, angry mother. My first advisory board meeting was 3 weeks after my daughter died. I will never forget that meeting because they didn't know who I was. They didn't know why I was there. They knew I didn't normally belong there because they all came and greeted me. The very first thing on the agenda was them saying that our hospital, Hershey Medical Center, was going to begin screening for Krabbe disease that month. So I was elated. I was like, wow, this is better than I thought. No. Then the then chair of the committee became my enemy that day. We're now friends and allies, but he was like, I don't understand why they would do that. It is such a waste of time, such a waste of money. He went on this whole rant. And I was like, oh no. Thankfully, I had 5 hours until the public comment time because I really needed to calm down. But then I was like, I let them know, and now I sit on a subcommittee. So obviously that story ended well. But I will never forget that day because I was like, what do you mean this is a waste of time? I had to change their minds. What did that take? Publications, which at the time we didn't have a lot of them. So I would go to symposiums and conferences and I would learn all this stuff that the researchers and clinicians were doing. And they were like, well, but it's not published. And then it would come out and I'd feel so vindicated. Anyway, the point of all this is I had no idea what I was doing. And to some extent, I'm sure none of you do either. And that's okay. As long as you are willing to learn and willing to listen. And yeah, then you can make things a reality. So as I sat in all those meetings, I started listening with fresh ears to how Pennsylvania did things. And I realized there were huge problems that needed to be solved, much bigger than the fact that they weren't screening for Krabbe disease. To name a few, Pennsylvania, in Pennsylvania, each hospital was actually screening for different things. I couldn't believe it as I'm listening to them talk about the fact that not all these hospitals had added conditions. And I'm like, what? So babies born in Hershey would be better off than babies born 15 miles away in Harrisburg. And I'm like, nope. And there were other things. And they were like, well, our hands are tied. We can't do anything about this. And I'm like, I can. I am a parent. So this is what I meant earlier. I do what I want. You have power as a parent and as an advocate that the Department of Health doesn't have. They have so many rules and restrictions, and you don't have those. So use that wisely, but use it. So, like I said, it took me 3 different bills, but finally we succeeded during COVID, I will add. Our third bill was introduced in January of 2020, and then COVID happened, and I was like, you have got to be kidding me. But thankfully, they kept adding session days, and so my bill actually went from committee to the governor's desk in 2 months. And the bill that we finally signed was stronger than the first one we introduced because we listened. This picture was taken 2 years after the fact because of COVID, but the boys got to be there. So listening to understand can help you understand the underlying issues in the state that may need to be addressed, is to not only see your condition added, but to strengthen the system for conditions to come. And as I mentioned, it takes all of us. We could not have done this if we didn't have the lab scientists and the clinicians and everybody that knew how all of this worked to better inform our stance. It was so important as we went along to honor and respect the experience and expertise that everybody brings to the table. And to be willing to collaborate. Even amongst the advocacy community, there is conflict, and it's really fun. And so one of the things that I've learned through all this that I'm actually good at doing is I am good at being neutral and bringing people to the table. That doesn't mean that I don't want to pull my hair out, but it's so important. They don't want to be approached by 5 different groups about the same condition. They want to be approached with, and this goes for even the FDA. Industry doesn't like to see the conflict among advocacy. I've learned so much about how important it is to collaborate. So I have some practical things that you could do today if you wanted to do. But the most important thing is to have a conversation. Who do I want you to have a conversation with? I would love for you to visit babiesfirsttest.org, or you can visit your state's newborn screening website. But they make it so easy to find the contact information for who is in charge of newborn screening in your state. I would love for you to ask them what hurdles your state's newborn screening program would face if they were to add your condition or if they were to try. And then you can see, are these issues that could be fixed by advocacy groups and how? And again, I'm not asking you to be like, I got to figure out how to fix this. Come to me, come to other people, and maybe we can help you. I mean, like I said, the most important thing you can do is listen to them. And I believe, and this is something that I've presented now to the MLD community twice, and this is how we have decided to approach this. We must communicate and operate transparently, constructively, collaboratively, which, like I said, means avoiding the duplication of efforts and coordinating our efforts. But we also must do this ethically. So in my work, I've had the privilege of speaking to, I don't even know how many state newborn screening programs now in the labs. And they don't like legislative mandate. And I know that that's the way that it has been done. But what I mean by that is advocates coming in, passing a law saying you have to do this. The states are not always ready. The bills don't always come with funding. And I'm going to give an example of Ohio for Krabbe disease. The bill that was passed by well-intended advocates. I'm not saying there's any evil intent or anything in this. The bill that was passed as it was going through the legislature was amended by politicians who saw that doing second-tier testing for cytosine was going to cost more money. They removed the ability for the state of Ohio to test for cytosine, which is the best biomarker that we have for Krabbe disease. The number of false positives that have happened in that state. So think about the trauma to these families because people didn't understand what was going on. It was terrible. So once you do a bill, like, it gets out of your hands. So that's why I really encourage advocates, if you can, to work within the established processes first and not jump to getting a law in place. I've actually been working for 2 years with people on a paper about the ethics of legislative mandate, and every newborn screening person that I've told, they're like, thank you, because it's just complicated things. Again, I'm not saying people have done it with bad intentions, but you can also attend newborn screening advisory board meetings. So 48 states have newborn screening advisory boards. They are required to allow the public to come and to comment. I actually attended 2 in the state of Texas virtually this year, and I was the only public comment, the entire state of Texas. So I just want people to know about these. Like, they do listen. They want parents to come and share. And Bob has served on the advisory board in Nebraska, so he knows. So build relationships and coalitions, and do everything with kindness and respect. You can create one-pagers or other resources, which I have some of those I can share too. Determine what has already been done in your state. So this goes along with the next one, which is examine the playing field and don't duplicate efforts. Be aware of who else might be working in your state to add your condition. It's very important. And that's all I'm going to say. If you want to scan this, you can. If not, the resources I'm about to show are also on ldmbs.org. But I have worked hard along with a couple of other people to develop resources to help all of you with all of this. So give you a second. It was fun to learn how to do QR codes for this. Okay, so When I first started LDMBS, it started with this spreadsheet, which I know not everybody likes spreadsheets, and I quickly learned that, but I love them. This spreadsheet is still publicly available, but nobody can edit it. It involves information about every single state's newborn screening program. To me, this is helpful. This is a roadmap. I can look at this and I can be like, okay, this is exactly what we need to do in Oklahoma, and this is what they're screening for. This is a very out of date screenshot. But I quickly realized that as parent advocates were looking at it, this is how they felt. And so I realized last fall, as I had a grad school assignment due that I didn't really want to do, I chased the dopamine, as my ADHD friends say, and I ended up creating this strategic plan that I have since been told by 2 different industry companies that I could have been paid a ton of money for. So huge mistake. But anyway, it's fine. I did this because it was fun. So if you want, again, these are on LDMBS for free publicly, but I created plans using that spreadsheet for both MLD and Krabbe disease. The one for MLD could most easily be translated to other conditions because MLD is not being screened for yet anywhere. Again, you don't have to, but if you want to look at these, I'll show you pieces of it. It does not translate well to slides. I also realize I am talking more than I planned to, so I'm sorry. Okay, so this is what you would see when you open the MLD newborn screening plan. So it begins with a timeline, which this actually is pretty accurate because the ACHDNC did accept our nomination package in June, which means at the August meeting, that's when they're going to decide whether or not to push it into evidence review. And then that means by the May meeting of 25, they will have to vote on whether or not to add MLD to the RUSP. So that's very exciting. In the meantime, Tennessee and Illinois are expected to begin screening this year, as well as Pennsylvania. Minnesota is also considering it. So what I did is I started with the timeline. I then took that whole spreadsheet and all these complexities, thinking about the states that have RUSP alignment, that have been favorable to adding conditions, all these different complexities, the ones that have treatment centers in the state. And I created this plan, and I figured out that I think for MLD, we can see every state screening by 2029. Can is the operative word. But I honestly think it's possible. And I wanted to do this to help advocates see and to feel hope, because that's what this did for me. Hope. So you can look at that if you want. Again, this is the same thing you already scanned earlier, or ldmbs.org/resources. We have, I didn't list the other things. We also have 1-pagers, and we have fact sheets for about 15 states now. Krabbe Connect has one for almost every state for Krabbe disease. And we're also about to release 1-pagers that are for specific states, like Michigan's actually the first one, that is kind of condition like neutral. And it actually says, call this number and talk to this person. And so it's customized to each state. And then these are 3 other really good places that you can go to get information about newborn screening. I have worked with all of these organizations, and yeah, it's good stuff. So to conclude, newborn screening started because of families whose lives had been upended and forever changed. And it is those families who have created a lasting change, and now we can be part of that. Do we have any questions about any of this? This is why Keely wanted to call it a crash course, because I know it's a lot.
Is your organization functioning as a clearinghouse? Like, we're going to be hitting newborn screening hard in the CTX community. I don't really know, other than this alliance, if there's other organizations out there working on this. I don't think so, but like, where would our information go on where the process stands if people wanted? Would your organization be appropriate?
Yes. So Maria's vision was always that we would be trying to encourage conditions to help other conditions. And so I already do have a little bit about CTX. Like, we have the map available on our website because I've been watching the progress. We will 100% do what we can. And the goal is, because I don't know a single Krabbe family in North Dakota. There may be one. It's going to be really hard to advocate in North Dakota, but there might be another leukodystrophy family that is willing to step up for these conditions and advocate. We can do that. You don't have to have been directly affected by that specific leukodystrophy to make a difference. So we would love to help. I honestly feel like you guys are going to have an easier pathway than a lot of conditions. because it doesn't involve stem cell transplant, right? Yeah. Right. You guys, isn't it a like a supplement or a pill? Yeah. Right. Yeah. CTX, I think you are going to probably beat a lot of us. and I want to help you do that. Something else I didn't mention because there's too much to mention in just an hour. There are 8 states with publicly available condition nomination forms and processes. Pennsylvania is now one of them because I pushed them to do it. So you can go on there, and once you have your RUSP nomination done, which it sounds like you do, you can copy and paste a lot of that just and attach the publications. And so there are 8 states, and I have all that in the strategic plan. And I even have links to all these things in the strategic plans. Yeah. So there are states trying to make it easier for advocates. And I'm glad that they're doing that.
I can add to what she's talking about because myself, I focused in on adding XALD to the Nebraska's panel. Well, at the same time, MPS 1 and Pompeii came on board with RUSP. So it was a no-brainer. Let's bring all 3 communities together and advocate that way. And this case, I killed 3 birds with 1 stone. But instead of having a multiple of bills come through, because that's what I was having to do at that time, because I couldn't, there wasn't funding available. So I had to get creative to get the funds coming in to continue the operation. So we created a funding mechanism and raised the price of what the state was going to get. But that was all it took. And that was a point in time where the budget was frozen. Jobs were not being added at the state level. And I actually had a couple of friends. One worked for the Businessmen's Association, so he was lobbying down there. The other one was a state budget director. And when it all got all said and done, they said, I don't know how you really did that because I didn't think you were going to get pulled through. So it takes hard work, but if you have a family in the state, that is obviously key because they're the key advocate for disease wise. But there are family members that are on these panels like myself and Lisa that we will help advocate and help people get through the whole process. And I think that's the key.
Yes. Thank you, Bob. Another thing about funding is that sometimes it's more challenging for these states because they have to literally buy a new piece of equipment. And we're not talking about like something you can get on Amazon. Tandem mass spectrometers are about $500,000. So if the state is told you have to do this, but we're not giving you any money to buy the equipment, what are they supposed to do? Sometimes it does require hiring another full-time employee because they have another machine they have to run. So it's just complex. And like I said at the beginning, I started all this as just a very angry mother who was like, this is dumb. Like, why aren't you doing this? To now where I am, where I'm like, okay, this is actually all just really complicated. Let's work together and fix this. And so I hope that if any of you are the angry parent that I once was, that this helps a little bit. We're all in this together and it does really take all of us. Do we have any more questions or are there any online?
Hi. Can you hear me? Oh, can't hear me. That's okay.
We can hear you.
Oh, you can hear me. Okay. Hi, my name is Diana. I appreciate your time and I can relate to a lot of what you've said. I am that angry parent and I am in Florida. My son was recently diagnosed with CTX and I've been wanting to get involved and I will get involved and use your resources to make a change. My son was diagnosed at 16 and so much could have been avoided had he been diagnosed earlier. So I also find it imperative for babies to be screened early.
Yes. And I will tell you, this is where I wish I had time to just go through each state and be like, this is what you can do. Florida actually has one of the best newborn screening websites I've ever seen. They do have a very active newborn screening advisory board that has authority. Not all of them do. Looking at
Okay.
Oregon, unfortunately. And they add RUSP conditions typically within 18 months. They're required to add them within 2.5 years, but their statute says that they have to at least make a decision within 18 months. So I would feel encouraged if I were you, but I would also go to the advisory board meetings, which should be online. I feel like I've seen the links, and just tell your story. And I don't know why I'm speaking to the speaker instead of the camera. I'm sorry.
No, that's okay.
Yes, because that's where your voice is. But yes, they do have public meetings a few times a year, and I would just encourage you to speak up and tell them this is coming. So be
Right.
prepared. And states do like to be first on things. So maybe you could also use that as a lobbying technique. You could be first.
Right. No, and I appreciate you sort of highlighting the fact of the collaboration and and listening to them as well and being informed of the challenges and making them feel heard so that you are not just seen as an angry, irrational parent, which I think can happen. That's why you
Oh, yes.
that
Like I
that
said,
lack
I fully admit I was one. Yes.
Yeah, exactly. But again, feeling unheard in general, even by the medical community, all the doctors that are unaware, where that too, the information needs to be spread, because I think that is the contributing, and that might be a whole other issue. A lot to say there too, and I don't know exactly how to begin changing that either. I've thought of making brochures. I don't know if they're
Yes,
going to
one pagers go a long way, especially if you have references like to journal articles
right.
and things like
So
that.
yeah, so
Mhm.
maybe especially if it passes to again start bringing that awareness, just again for doctors to look. That was a big problem with us, with my son, which is obviously what we probably all share, was that I went a doctor after doctor, test after test. Everybody's looking at me. I keep saying something's wrong, and you feel completely unheard, and your child continues to be sick. And
Yes, absolutely.
so.
I know that devastation, as a lot of people in this room do as well.
Yes, exactly.
Yeah.
So thank you for all of your work.
You're welcome. And yes, if CTX does have some kind of one pager, we do have a meeting in Pennsylvania on the 18th, and I'm already bugging them about MLD. So I will happily just. Yes.
Okay, so with CTX, one of the things I know we're going to run into is that we definitely don't have patients in every state. So do you happen to have like people that you know of that we could contact, other leukodystrophy families that might be supportive in their state once we get to that point? Because even putting things out there just within our board and everything, there aren't a lot of different states for us.
Yeah. So that's something we're continually trying to build. And we do have Krabbe and MLD families. And I mean, the ALD community would be another good one to meet up with, because that is more prevalent. ALD is much more prevalent than a lot of our conditions. Yeah.
Got a question online, and as well, feel free to reach out to the ULF. We are happy to talk to patients that we know in different states.
Oh, good call. I
see
should
if
have
they would
given you a
be-
plug.
Yeah, well, yeah, no, I mean, like A would give you a lot of support for everything. That's a no-brainer. And B, we'd reach out discreetly to people, because some people are overmatched and we may not know that. But I would be happy to try and link you up with people in different states that you don't have representation.
Mhm.
Yeah, and that's something we're going to try and formalize over the next 12 months, is to get advocates, disease, fighters for leukodystrophies in general, not necessarily just MLD or CTX or MLC for my family, but for Louisiana or Texas or New York or whatever. So by all means, reach out if we will definitely try to help you. You can definitely get a letter of support from us on all of this, and we're going to try to be more active. We have not been. Bob's been incredible, but the rest of us have not been. So on that, I'll pass you along the contact information as well for the lady from Florida. And I have a question here. She wants to know, is there a map that shows which states and screening labs and which ones depend on other states?
I don't have a map. I just have a chart.
Do you want to read them out one more time, maybe slowly? I think there was. Yeah.
Yes, let's go back to find it. Yes, right now there are 12 states that use another state's lab, and then 4 plus DC that use Revity. Which actually, that's another good thing to ask you. Does Revity have, there's the states slide. Does Revity have the CTX assay done? Okay, good. That's a good marketing tool too. Like they just finished their MLD kit and it's up. So now we can say, hey, states, here you go. You can buy the reagents. You can do this. And then I wanted to mention one other thing about not having somebody in every state. The good thing too about going through the experts is that they understand that these diseases are rare. And I think they're more willing to listen to an advocacy group versus a state resident, whereas a legislator would only want to work with somebody that lives there.
Labs used to then just absorb possibly the other states? I mean,
Yes. So I wish my strategic plan worked well on slides, but it does not because it's pretty in Canva, but it looks terrible. In there, I actually did use that as my criteria for where we should focus. And I listed the reasons why. So like this morning when I talked about Krabbe disease, I mentioned that Massachusetts is on the list, not only because they screen for all those other states, but they also do have a formal process to follow. That is, they're working on having the form publicly available, but they're going to have it any day now. And so it makes it so easy for us to just copy paste, submit, get it going in the process. So I did use that as I was determining which states we should focus on.
okay, so the states that are, sorry,
No, it's fine. It was just funny to see that.
it's getting the words together.
Yep.
The states that are using the labs, okay? If you go after those states, okay, and if they commit to newborn screening, is it a guarantee that the other states who are using them, it is not a
No.
guarantee? You
No, they
still
all
have to-
still have to make the decision to do it because it's going to cost them money.
Okay.
But I will say in the example of Iowa, the other 3 states screen for everything Iowa screens for. There's no discrepancy, but but New England is not that way. There is a discrepancy between what Massachusetts screens for and what the other states have chosen to.
Okay.
Yeah.
I kind of want to tie in too with the comments about limited people, but child neurologists, pediatricians at your children's hospitals can be a good resource because they know these diseases enough and they can be valuable. And they may have even had a patient that you haven't even contacted. So that's really a
point,
good
yes.
place to me, is a good place to start.
And even if they can't give you the information, they could give that person your information. Yeah, that's a great idea. This is why it's so happy. It's so much better to just be kumbaya and like everybody work together. But yeah, I mean, Every Life in Nord and those other really big rare disease organizations are really good at connecting people too.
I have a question.
This ties into what Rob was saying, Mr. Rauner. After the diagnosis, well, after the result is, say, positive for any of these conditions, what mechanism is in place to support the families, to educate the families? Does that also happen on a state-by-state basis?
Yep. So this is why states have follow-up programs, and they try to stay with the families and watch them to some extent, but this is where it also falls on advocacy. There's way too much that falls on advocacy groups that are nonprofits or volunteer run. But this is just the reality right now because the states can't be experts in every condition. But that's also why it's hugely important that when you're advocating, you make sure that the state has important information. Like, does CTX have an ACT sheet through ACMG? If you don't know what I'm talking, I can look it up. So a lot of states rely on these information sheets that the ACMG, the American College of Medical Genetics and Genomics, puts out about a condition, and it tells them like it even includes the advocacy groups that they can refer families to. So that helps the clinicians know what they're supposed to do with these patients. It is not a perfect solution, but I do know that the follow-up programs are very, very passionate about doing the work they do. Do we have any other questions? Because we are almost out of time. I love these questions. Thank you. And I'm always available, like too much available probably, but this is my absolute favorite thing. But most importantly, I view advocacy as how I continue to be Tori's mom. She is no longer here, but I can keep her alive by me trying to help other people do the same thing for their children. So this is what I love to do. There's always more to learn, but I don't want you to feel like you have to know everything I know to be an effective advocate, because you don't. So just let me know if I can help you. All right. Oh, Lisa, yes. Yeah. Lisa Brackbill. My address is just lesa@ldmbs.org. I normally have that at the end, but I don't today. Sorry. But thank you so much.